We have come through an era, those of us of a certain age particularly, we've come through an era where we could simply focus on each and every patient without regard to resources, without regard to considerations of distributive justice, really. And that era is over. The urgency now for cost containment is so pressing that it's at our peril that we ignore it. Now, how we effectively contain costs is the tremendous challenge.
Primary care and medical professionalism can be a steward of scarce resources. But that means that those kind of wishes need to be determined. It also means that the primary care physician, as part of professionalism, needs to say no to patients sometimes. When patients come in and demand treatments that aren't going to benefit them, we have to have the courage to say, this isn't going to help you, and I don't recommend it. And I'm not going to refer you to a specialist because it's not going to help you. Those are hard conversations to have, but they're important ones to have.
For physicians to make these decisions about making wise use of resources, first of all, they need to understand themselves much more about the cost of actual interventions, and more particularly the cost-benefit trade-offs of particular interventions. They need to understand comparative effectiveness of various interventions. They need to understand concepts like quality-adjusted life years. And again, it's not as if they have to sit there making that calculus every time they prescribe something for a patient, but just to come with to medicine and to the practice of medicine with that general mindset. Because patients are also insulated from the cost of many interventions because of insurance and other factors, it will take some additional steps, I think, to educate patients about the costs and to have them realize that, yes, a particular intervention may not cost them all that much, but if it's less cost-effective than something else that may be done, society is still going to bear the cost of that intervention in some greater way, and eventually that's going to show up in somebody's health insurance premiums.
I think we can be tremendously articulate to help physicians understand what patients really do and don't need and want. I think there's often this kind of projection on us about what it is we want and what it is we need and how it is we will or won't. I heard an example of this recently in a group setting where a patient was talking to a group of doctors and said that she felt, and she herself is a consumer advocate, and she is a kidney transplant patient whose second kidney failed. And she told the story to the group that she felt that it would not be the best use of resources for her to have a second kidney transplant, even if she had an appropriate donor, because she does well on dialysis. She's already had one kidney and it failed. She obviously has some pretty profound systemic issues. It's a risk to her, it's a risk to the donor, and all those aren't worth taking. I saw many of the physicians in the room get this big look on the big eyes, look on their face, thinking, why, I never thought I'd hear a consumer say that they didn't think that was the best use of healthcare resources. But first, we need to learn how to talk to those consumers. We need to learn how to describe to family members what these interventions do and don't do, what they do and don't mean, what kinds of side effects there are, and we have to allocate the resources to those conversations. Because what's happening is, we're coming into the ICU, all hell breaks loose, everything's flying everywhere, and it's not a great time for this conversation.